Hello and welcome. My name is Michelle Gershberg. I'm the U.S. Health Editor for Reuters, and this is a Facebook Live Q&A. We've titled it The Coronavirus Pandemic, Global Race for a Vaccine. With me is Barry Bloom, Research Professor of Public Health and former Dean at the Harvard T.H. Chan School of Public Health. You can post your questions for our conversation on Facebook at Forum HSPH, or you can email them to the forum at hsph.harvard.edu. You can also watch this Q&A on Reuters website. This Q&A is presented jointly by the forum at the Harvard T.H. Chan School of Health and Reuters. Welcome, Barry. Thank you for joining us.
I'm pleased to be here.
Let me start by asking the question that is at the top of everybody's mind in this pandemic. When can we expect to have a vaccine?
So the key word in that question is, who is we? It is likely, and I think almost certain, that at least one of the 9, and probably more of the 9 in late phase clinical trials, phase 3 trials, will be shown to be safe in phase 3 and effective, meaning the bar is 50% protection against disease or better. We all hope it's better. But the key part of the question is that may make the vaccine approvable by the end of the year. When will people get it? There'll be a limited supply because no one has the capacity to produce all the vaccines at the moment for the US and for the world in one fell swoop. So on January 2nd, there will not be enough vaccines to protect everybody. And that leads to some critical decisions of who will be prioritized to get the first vaccines. And second, when that's possible, who will agree to take the vaccines? And those are the key questions that answer the question, when will we, ordinary people, have access to a vaccine to protect against COVID?
So you mentioned January 2nd, but a lot of the conversation right now is centered on the possibility of a vaccine being considered or authorized for some group of people by October. Does that seem realistic to you?
So I think this is an important scientific issue that's got to be made clear, and that is in the protocols for clinical trials to decide if a drug or a vaccine is effective, time is not a major component. The decision as to whether a vaccine is protective and safe depends on the statistical data that shows that a fixed number of cases that would predict whether the vaccine is safe or not in the mix of the vaccine group versus a placebo group, whether those statistics give you a high degree of certainty that the results are either the vaccine is effective and safe or it is not. That depends in this trial on how many cases there are in the many centers that are doing the trial. So the endpoint is the number of people who get sick. It's not a calendar date. It's the data, not the date.
So absolutely, I appreciate the point. In fact, there is a question of whether or not those statistical benchmarks should be shared more widely among the scientific community, people who are not directly involved in the vaccine development project. Do you have a view on whether or not they should be made publicly available?
It is unusual in trials to make data available because the essence of a good trial is to be double-blinded, so that the physicians don't know what they're injecting and the patients don't know what they're injecting, and the company that makes the vaccine doesn't know who's getting which vaccine. So the question is, what do you want to be made public? So the safety valve on all trials is something called the Data Safety and Monitoring Board. And this is a group of experts representing the scientific community, drug approval and regulatory stuff, legal, and the companies or people with companies but not directly involved in the trial. And they're the only ones during a phase 3 trial that have access to the data on an ongoing basis. And their job is to look for one of three things. Is there an adverse effect that might be caused by the vaccine? Is the vaccine so poor that it is clear there is no reason to put anybody at risk to get further vaccines or for drugs or further drug? Or are the results so clear-cut that you don't have to have 30,000 people in the trial? The data are so clear, a recommendation could be made that the vaccine be applied for a biological license application, which is what the FDA is able to issue that makes the vaccine publicly available. It is unlikely that I think a vaccine will be so spectacular that there would be reason to stop the trial because any vaccine is so clearly perfect. We're hopeful that there's not enough adverse effects that they have to stop it, but I would point out the pause in one of the vaccine trials from AstraZeneca because of two patients that had potential serious adverse effects proves that the system is working. It did exactly what should be done when anybody is sick, to hold things up and investigate whether that's related to the intervention or not. And at least in England, they've decided that those clinical symptoms were probably not caused by the vaccine, and they have resumed the study.
So thank you for bringing up that case in the AstraZeneca trial. While the trial, so as you're saying, the system has worked, right? So trial investigators, were aware and they stopped to investigate. The information, however, was not made public until it was reported in the media, at which point AstraZeneca disclosed more widely that this was happening, that this pause happened. Now we know generally in clinical trials, this information does not have to be disclosed to the public, right? But I'm wondering, under these circumstances, with everybody watching this race so closely, do you think that vaccine developers should think a little bit more differently about how quickly they disclose issues like this for the sake of transparency?
Michelle, it's a tremendously important point. In the ordinary circumstances, there's not a great deal of necessity to give interim reports. If in a trial of 30,000 people, one can expect somebody to have a heart attack, somebody to have a stroke, somebody to get run over by a truck, someone to have some other adverse effect. And the point of the Data Safety and Monitoring Board is to establish whether any of those conditions, all of which have to be reported by every center doing the trial, whether they have anything to do with the vaccine. This is a very special situation, not least because it is not just a scientific routine issue of one more trial. This has become news every country in the world. This is a political issue. And I think your point is well taken, that the companies and the government should be as transparent as possible, still protecting, obviously, individual personal privacy and rights, to tell what they know at the earliest possible point. Because one of my two favorite lines about vaccine is the critical ingredient in every vaccine is trust. And without trust, the vaccine doesn't do an awful lot of good in the world. So I would support your point that the company should be very clear at every level, both about the science and the concerns about, for example, stock sell-offs, that people are bailing out of the companies that are actually making the vaccines. Does that imply a lack of confidence in the vaccines? That's not helpful to public trust, which I think we must have if we want lots of people to be protected with these vaccines.
Do you have any concerns about the portfolio of vaccines in development given the speed with which this process is unfolding?
I think it is fantastic that within 65 days from the publication by the Chinese scientists of the cDNA sequence for this new RNA virus, the first Moderna vaccine was put into the arm of volunteers in phase 1 trials. 65 days. Nothing has been seen like that. And for many of the other candidates, it's very much the same. The quickest vaccine that has ever been approved for use took 4 years. The longest I am told is 27, but if you look at polio, it actually took 50 years from the march of dimes till the vaccine was actually in use. So this is the scientific world working at warp speed. What we have is assurances at many, many levels that will not compromise the objective scientific evidence-based analysis of whether the vaccine is safe or effective. But as I said, the answer to those questions depends on the numbers. And if you have 30,000 people and there's a high rate of infection in the community, you can get that answer perhaps by November, more likely by the end of the year. That's enough to say the vaccine is safe and effective as far as we've studied it. And what I want to emphasize is with either an emergency use authorization or a full license to sell vaccines, it doesn't stop there. And that's commonly not appreciated. These vaccines that once they get approved will be followed for at least a year, and I would hope 2 years, so that as they are disseminated widely, what we're concerned about is we've got data in the trials to say they're safe. There are no serious effects that seem to be caused by the vaccine. There'll be minor adverse effects, sore arms, fatigue, perhaps fever, but nothing seriously to worry about. What happens a year from now if the vaccine comes back? What happens to people who've already been vaccinated when they get reinfected? And that requires what's called a phase 4 follow-up, post-licensure surveillance. And that is part of the FDA protocol that will be put into force for vaccines that are approved once they're approved. So I am hopeful we will have long-term follow-up to be sure they're safe. And of course, at any point at which they appear not to be safe, there'll be reconsideration of pausing or stopping.
So we've laid out, or we've discussed the US regulatory process, but as this is going on, in Russia and in China, the vaccine developers are inoculating larger and larger groups of people outside of clinical trials before they have full data on the trials that they are running or planning to run. Does this impact the discussion or the public perception around vaccines and the safety of those vaccines?
This is not appreciated in the scientific community, where I think there are universal understandings. They're as universally understood in China and in Russia as they are in Europe and the United States. People understand why you need phase 1, 2, and 3 trials. People understand why you need big numbers to be able to get rather infrequent adverse effects if they occur, to get a better idea of how effective the vaccine is, so we have some idea how much closer we get to community protection or herd immunity. The Chinese and the Russians have short-circuited that to give them on a wider scale than the scientific evidence in any rational view would have permitted. I think that has made the situation even more political. This is not a gain for any one country. A vaccine or multiple vaccines, ideally, that work is a gain for the whole world.
And then again, on the global scene, the World Health Organization is raising money to create an equitable distribution network of vaccines around the world, right, to target high-risk populations and try and help curb the pandemic. The United States has not joined that effort, and I'm wondering how you see the role of the U.S. on a global level. At this point, I think we have some statements of commitment that the U.S. would provide to other countries, but we don't yet quite have a roadmap of how that sharing would take place. How would you see the U.S. role in the global vaccine effort?
So I've been involved in tropical diseases, tuberculosis, and leprosy with the World Health Organization since 1967. It has many, many flaws, but it has a unique legitimacy. It is governed by 194 ministers of health of every country in the world. And it has an authority that no individual government or foundation in terms of best practice. It's very sad to see the United States withdraw from the World Health Organization at exactly the time in the middle of a unique pandemic when developing countries that do not have the capacity for the science or developing industrial production of vaccines are increasingly vulnerable and not willing to have us participate in a formal way. We know that international and intergovernmental organizations are highly bureaucratic. It was once said you can't use speed and intergovernmental organizations in the same sentence. On the other hand, there is a matter of equity, and they are doing their best to be sure that every country will at least have some part of the vaccines within the first year, not necessarily the first week, to protect the essential healthcare workers and many of the essential workers within society. We have not participated in the World Health Organization. We have not had a representative to the executive board, which is the board of 32 people who recommends policy to the director general there. And we are not part of the international effort to pool funds, resources, and share vaccines. And in my experience of all those years, the US has been seen as the leader in global health, the leader in science, the leader in the commitment of science for the benefit of people around the world. We have withdrawn from that role. And I think that's bad for the US and certainly not good for the people in low and middle income countries around the world.
I wanted to get back to a point you made about the follow-up, the long-term follow-up for vaccines, and are there any adverse events or other complications that arise over time? We know that the U.S. has a special fund to compensate people who experience any kind of harm after receiving a vaccine. But we've also seen and reported, as have others, that only a small fraction of those claims ever get approved. It's meant to be a way to expedite it. How important is that kind of compensation or the ability for the small fraction, hopefully, of people who might experience harm to have recourse and to seek some kind of compensation?
That's a very, very sharp question. Let me start at the beginning of my experience with that. There's something called the National Vaccine Injury Compensation Fund, about which as a scientist I knew absolutely nothing. And what I learned that is in 1980, there were 14 vaccine producers in the United States, many of them state health departments, including my own in Massachusetts. By 1990, there were 4. And the reason there were 4 is that legal suits for injury, malpractice or injury suits, at about $1 billion per suit, for child whose health condition was alleged to be caused by the vaccine was a huge disincentive to a company to make vaccines. Because if vaccines work, you don't need to take them all the time. But if you have a pharmaceutical company that also makes drugs for heart disease or diabetes or many other chronic conditions, you can find it much more lucrative and very fewer lawsuits. So we almost lost the incentive to companies to make vaccines. And the Vaccine Injury Compensation Act indicated that we recognize that there is no vaccine that is 100% effective, and there's unlikely to be any vaccine that doesn't have an association with any adverse effects. People are just so heterogeneous in the world that a vaccine that is safe in almost everybody will have 1 in a million for idiosyncratic reasons that may get an adverse effect. So that has protected the vaccine industry to keep them in business, and has also protected the families of any child, because it's been mostly childhood vaccines in the US, that may have an adverse effect that is defined by a committee of the National Academy of Sciences. There are legitimate outcomes that might be attributed to vaccines, and there are lots of claims that couldn't possibly have anything to do with vaccines. And those families are entitled to lifetime lost earnings and medical compensation without having to hire a lawyer and without having to go through a long legal battle. And so it is beneficial for any family that has been judged to have had a child, or in the case of an adult vaccine, potentially injured by a vaccine. It has been a very successful program in that it doesn't preclude anyone from hiring lawyers, and in addition, or instead of, seeking legal remedies. But the number of legal suits against the vaccine companies has been so small, it says that program has been largely effective, both for the companies and for families that have children who might have been injured.
I'm going to bring in a question from our audience. The first one is, do you envision coronavirus vaccines being licensed for children in the United States with an emergency use authorization prior to receiving adequate testing?
I don't anticipate that. As you know, one runs vaccine trials in general for safety and efficacy in a population likely to be relatively healthy. And so in these trials, they are mostly, in fact, all restricted to an age population between 18 and 65, so that there are two populations that are not being evaluated in the initial phase 3 studies of the current vaccines. The people at highest risk for dying of COVID-19 are people over the age of 60. And they have, in the phase 1 and 2 studies, not been included. They have been included in the phase 3 studies at some percentage. And back to transparency, I can't tell you for which vaccines what percentage of the 30,000 people will be over 60. That has not been made public to my knowledge. The other group that is not included in the vaccine is children, because I think because of the special vulnerabilities and importance of kids, one doesn't want to put anything into children unless one has good reason to believe it is likely to be safe. And that means you have to run the trials in adults before you start on children. I would hope, if the results are so spectacularly clear that the injuries are minor, that there will be studies immediately after approvals to show that it's safe in children. We're lucky with COVID in that children seem to be the most resistant to the adverse serious consequences of hospitalization and death of any age group. So they're not the most vulnerable, which they would be for many other infectious diseases.
I'm going to bring in another question from the audience, and it kind of echoes other comments that we've heard. is really the overall question of how do we inspire confidence in a COVID vaccine in view of the increased amount of vaccine hesitancy seen nationally. How do we as health professionals inspire confidence in this vaccine as well as others that people are concerned about?
That's a really key question. I think most of us in the scientific community are optimistic that several of these vaccines, and there are many more behind them, are going to be found to be safe and effective and be made available. And since no one company can produce enough vaccines, maybe 5.6 billion doses required for the whole world, or 200 or 250 million for the US, we will need multiple vaccines. But then in the circumstance where trust is so important, and there is such skepticism, at least in our country, about whether people are getting things straight from the United States government at any level, how do we do that? And that's going to be a huge challenge. And I would say two thoughts. The first is, if you look at who are the most trusted professionals in the United States, it would be doctors, nurses, and pharmacists. And they're the key people that are trusted by the public in general. They may not trust the medical system or the government, but almost everybody trusts their physician. So that puts a huge opportunity and responsibility to get the most transparent, the most up-to-date, and the most accurate information in a form that ordinary people like you and me can understand, to enable them to make a decision that they want to have the vaccine for their family or their children or their grandparents. So that's a key first line. The second is we live in a different world than we did for any other vaccine. We have, since the beginning of vaccines, the first anti-vaccine organized society was in 1886, and it has persisted in many vaccines that were developed after smallpox. So there's always been a small group who fight for their independence to make decisions rather than believe it is worth the public good to have everybody protected. What's different now from 1886 is the social media, the disinformation and misinformation from people with political agendas, and we now know from other countries misinformation, which makes it only more difficult for people to get the information they need to make a decision. And for that, I think we need two things. I would refer back to the last time there was a really good campaign of advocacy and information to encourage people to take vaccines. And that was called the March of Dimes. And that was a foundation that was completely independent of the United States government. We happen to have had a president, Roosevelt, who had poliomyelitis. And we had the March of Dimes, where every child in the country was encouraged to contribute a dime to protect other kids from being paralyzed. I'm impressed that that was effective. I'm impressed that the private sector has a role to play, which they haven't played since the March of Dimes in a serious way. So that's the second level beyond physicians, nurses, and pharmacists. And the third level is this disease is highly localized. It affects individual communities. If you look at just New York City, the data are that there's using antibody tests, there's a 20% difference between the incidence rates in one borough of New York City versus another borough. And that means you have to get to the community level to persuade people and inform people to make judgments that this is good for the Latinx community. This is good for the Jewish religious community. This is good for the African American community. This is good for the Wall Street community. And that has to be targeted information. And in my experience, one has only to look at advertisements on television to know that the private sector, the ad council, the advertising industry has a much better way of presenting information to people in a persuasive and compelling way than dull scientists like me and my colleagues.
Barry, thank you so much. I think we are at time. Is there any parting thought that you want to leave our audience with?
I think that the critical issue to end any pandemic is to interrupt transmission. So we are hopeful that these vaccines, if they're effective, will stop people from getting sick and dying. And that's an enormous value. But the best of them, which may not be in the first lot, are those that also prevent people who are infected from transmitting to everyone else. And if we have such vaccines and it's available to the world, we can stamp out this COVID-19 epidemic worldwide. That's my hope.
Thank you so much. That concludes our Facebook discussion. This Q&A has been jointly presented by the Forum at the Harvard T.H. Chan School of Public Health and Reuters. You can view the full discussion on Facebook at Forum HSPH and on the Reuters website. Thank you, everybody.